Greetings and welcome to this session 4 on antibiotics lecture series. In this video, we'll discuss about beta-lactams and beta-lactam inhibitors, shortly called the BL-BLIs. So these includes penicillins, Piperacillin-Tazobactam, Sulbactam. This is completely for educational purposes and practicing physicians. This is medicine beyond Harrison's. Let's get started. So, most ICU mistakes happen because not because of the beta lactams are weak, but because we overestimate what the BL-BLIs can do. So, often using BL-BLIs for MDR organism or ESBL producing organisms leads to failure. So, in case of an ICU and patient is on septic shock, better to go for a carbapenem drug instead of a BL-BLIs. So, and later to de-escalate. That is a good practice point in ICU when the patient is in septic shock. So one mechanism is there is many consequences. So the main core mechanism of beta lactams is that it inhibits the cell wall synthesis. It binds to penicillin binding proteins. It is bactericidal. That is the most important feature of these group of drugs because it is bactericidal. It can be used in bacteremia to clear off the organisms fastly. So this is a time dependent killing. So that means infusion strategy is more important than the dose size. So Piperacillin-Tazobactam is given over 3 to 4 hours instead of giving 100 ml directly. So sustained exposure leads to more response than the peaks. So penicillin family and subgroups. We have two main subgroups. It is the aminopenicillins and the anti-pseudomonal penicillins. Aminopenicillins are ampicillin, amoxicillin. This covers the common organisms such as Streptococcus, Enterococcus, and Listeria. So the drug of choice for Enterococcus should be ampicillin with or without gentamicin. Streptococcus easily responds to amoxicillin, while Listeria it responds easily to ampicillin. So ICU role is the targeted therapy should be given, not the empiric therapy. So the aminopenicillins are destroyed by common beta-lactamases. So when the culture report shows ampicillin or amoxicillin is resistant, that means that bacteria is an aminopenicillinase producer. So that means it destroys ampicillin and amoxicillin. That doesn't mean these organisms are multi-drug resistant. It should be easily sensitive to third generation cephalosporins. So other group of beta-lactams are the anti-pseudomonal drugs, mainly the piperacillin and ticagrelin. Nowadays, it's rarely used alone. It is often combined with the beta-lactam inhibitors. So it is always combined with inhibitors in the modern ICU practice for better activity. So beta-lactam inhibitors, this is the most important new generation concept where beta-lactam is combined with a beta-lactamase inhibitor to us to protect the penicillin. So it is said that they do not fix the resistant mechanisms beyond what it does. It just protects the penicillin from being destroyed. That's it. But if the organism is resistant to penicillin, then the beta-lactamase inhibitor is cannot be used for this organisms. So this inhibits some enzymes do not magically expand the spectrum of the primary drug. Okay, can be clavulanate often combined with amoxicillin. Sulbactam often combined with third generation cephalosporins such as sulfarazone. Tazobactam is often combined with prazolam. So these are the group of beta-lactamase inhibitors often used in combination. So coming to amoxicillin and clavulanate, it has a coverage profile for community gram-positive organisms, including Streptococcus, and common organisms like H. influenza. So it has coverage against anaerobes also and some rare gram-negatives. So it can still be used for urinary tract infection in case of pyelonephritis if the organism is sensitive. So ICU limitation is not used for sepsis. It is not an ICU drug, not for pseudomonas, not for ESBL. So it is basically a drug that can be given as an OPD basis for treatment and not a drug used in the wards or ICUs. Piperacillin-Tazobactam, why it is so popular is because it has a broad gram-negative activity, covers most of the organisms, including Pseudomonas, anaerobes, and Enterococcus. It has a very broad spectrum of activity. Even the Enterococcus fecalis is being treated by Piperacillin-Tazobactam. Only the Faecium is inherently resistant to Piperacillin and other third-generation cephalosporin drugs, for which we might need to use vancomycin and other drugs. So IDSA approved uses are is used for empirical sepsis, intra-abdominal infection, ICU pneumonia. So basically, most of the infectious diseases are comes under the spectrum, such that piperacillin-tazobactam becomes one of the most important empiric drug of choice. So clinical limitation is that piperacillin-tazobactam is not reliable for ESBL bacteremia. Even if lab says sensitive, the MERINO trial says clinical failure is due to inoculum effect. So it can still be used for urinary tract infection and gallbladder infection. It has a very good inoculum effect. Otherwise, it has a high clinical failure rate also. So IC rule is the main thing with Piperacillin-Tazobactam is that it needs extended infusion strategy. That means Piperacillin-Tazobactam in 4.5 grams should be given over 3 to 4 hours so that the time in range is maintained well above the minimal inventory concentration to make the drug work. So other group of this drug is the Sulbactam. It has a high gram-negative spectrum, and some Acinetobacter is also covered due to the Sulbactam part of the Sulbactam. Compared to Piperacillin-Tazobactam, it do not have Pseudomonas coverage. Although some sensitive Pseudomonas can be treated with Sulbactam. In reality, it is mainly used in India-centric regions where most of the data are conclusive for usage with Sulbactam and the organisms getting inhibited. So IDSA view is that it is an acceptable empirical treatment, but it's a weak definitive agent. It has a less global outcome data. There is poor de-escalation pathway once you go for a Sulbactam. So according to Sanford or IDSA, it is ceftriaxone or heavy that is preferred over Sulbactam. But still in Indian-centric regions, Sulbactam usage is too high and has good potential for treatment and recovery. So why a BL-BLI drug can fail? So this knowledge makes you a pro in antibiotic treatment such that you avoid using the drugs that could fail in these kinds of patients. So when you suspect a ESBL or when you see a culture report with an ESBL organism, the lab might say sensitive. The clinician can trust it, but the patient will deteriorate. So BL-BLIs are failed in extended spectrum beta-lactamase producers. These extended spectrum beta-lactamases also inhibit the beta-lactam inhibitors so that the primary drug will not be of good use. So AMC induction. AMC is an inducible enzyme produced by the bacteria when you treat it with a common drug. Enterobacter, these are spice organisms that we have discussed in the previous module. If you have not seen that module, please go and see that module. It is a spice organisms as for Serratia, Providentia, indole positive organisms, Proteus, and Citrobacter and Enterobacter cloaca. All these organisms have inducible AMC production. So even if the culture report shows it is sensitive to Piperacillin-Tazobactam, initially it will respond. Later, due to the production of AMC by induction of the bacterial enzymatic pathways, they will become resistant to Piperacillin-Tazobactam and patient may suddenly deteriorate. So, for an AMC producing organisms, if you see it in a clinical report, better to go for a third generation cefepime or a carbapenem. So pharmacokinetic failure is that if you not give a cephalosporin sulbactam over 3 to 4 hours, then the pharmacokinetics will fail for that drug. The area under the curve, if the patient is also having augmented renal clearance, the sensitive bug can even survive. Even the sensitive bug survives in this pharmacokinetic failure. Always, we know the right route, right drug, right dose at the right formulation in over the right time to achieve the adequate pharmacokinetics of the drug. So decision, it's when you see a community-acquired gram-negative sepsis, BL-BLIs can be given as the first choice, either the cephalosporin sulbactam or the Piperacillin-Tazobactam. In case of pleural sepsis and with non-ESBL organism, you can again go for BL-BLI combination. When an ESBL is suspected, avoid BL-BLI, straight away go for carbapenems. When ESBL pure bacteremia is present, always go for carbapenems and not BL-BLIs. When AMC organisms are present, go for cefepime or meropenem. In the de-escalation phase also, BL-BLIs should not be used. It should be de-escalated to further a better drug, probably a ceftriaxone or a third generation cephalosporin. So, for example, if you have a case with E. coli urosepsis with a non-ESBL producing organisms, it shows ceftriaxone is sensitive and blood culture is positive. You can initially start with the Piperacillin-Tazobactam dose, and later you can de-escalate to ceftriaxone itself because of superior definitive choice and the most tested pharmacokinetic drug is ceftriaxone compared to Piperacillin-Tazobactam or cephalosporin-sulbactam. So magnets can be sensitive, but it's not the best because ceftriaxone has the most tested efficacy against these kinds of non-ESBL organisms. Hence, with a once a daily dosing with 2 grams IVOD, it becomes the best drug of choice and becomes the definitive choice. So BL-BLIs are just bridges. These are not destinations to go. BLIs are used to stabilize the beta-lactams and then move on. So common error is just that BL-BLI combination can be used for carbapenem sparing. That is not correct. So you can use it in such cases where you do not suspect a ESBL organisms. If you give a wrong BL-BLI and it's failed to initiate a delayed carbapenem, failed to initiate a carbapenem or delay in giving a carbapenem, there will always be a high mortality risk. So, case selection is very important. With the history and detailed examination and the clinico-radiological correlation, we often start an antibiotic and de-escalate or escalate according to the culture reports. This is the main mechanism. So, just a small question before completing this module: why Cevipime is preferred over Piperacillin-Tazobactam for AMC organisms? So, even though the Piperacillin-Tazobactam is broader activity, covers Pseudomonas, covers anaerobes, but still Cevipime is preferred for AMC organisms. So, why is that? You do not answer now. If you know, just leave it in the comments. So, learn something in this module about beta-lactams and beta-lactamase inhibitors, commonly called the BL-BLIs. Let's meet in the next another video. In the next module in this antibiotic series, we'll cover about the third generation cephalosporins and other cephalosporin drugs. This is medicine beyond Harrison's. Thank you for watching.